Okay, we're good to go.
Is it recording?
Yes.
Sorry, I didn't hear it. All right. I'm sorry. Good afternoon, everyone. Welcome to Emory's MCI Dementia webinar series. We are so glad you could join us today. This webinar is part of an educational series that is sponsored by Georgia MemoryNet, Integrated Memory Care, the Emory Cognitive Neurology Clinic, and the Charlie and Harriet Schaffer Cognitive Empowerment Program. Each month, we have a different topic that relates to cognitive health, dementia care, support, community resources, just to name a few. The previous webinars have been recorded and can be viewed in a link that we will place in the chat. I am Alice Cooper Salisbury, one of the licensed clinical social workers in the Cognitive Neurology Clinic, and I'm joined by my colleague, social work colleague, Debbie Arnold, NCEP, and she's going to introduce our speaker in just a moment. And this webinar format, just so you know, for housekeeping details, means that your cameras are off and your mics are muted. We do want you to be able to participate, though, and ask questions or make comments, make a statement if you need to. But that will be done in the Q&A box where you can submit the questions throughout the presentation. We may be able to answer some of the questions during the presentation, or if we can't get to them during, then it may be at the end. But please, please, please submit your questions or comments. All right, and on that note, I am going to turn it over to Debbie.
I have the special privilege today to introduce one of our own, Ashley Varner. Describes herself as a clinical social worker through and through. And those of us who are fortunate enough to work with her endorse that description. She has been in practice for nearly 30 years. And she's been able to work in a wide variety of medical settings, in hospice, nonprofits, and as social work faculty. She has also published a number of book chapters and journal articles, and her PhD dissertation was caregiving, the hardest job you'll ever have, a qualitative study of caregivers of those with cognitive impairment. She currently practices in Emory's Cognitive Neurology program, where she sees clients and caregivers affected by mild cognitive impairment and dementia. And she's also our clinical lead for psychosocial services for Georgia MemoryNet and the manager of outpatient neurology social work for the Emory Clinic. While Ashley obviously enjoys formal schooling since she's got all the letters after her name, she always says that her greatest teachers have been and continue to be the clients, family members, her colleagues, and supervisees that she works with on a daily basis. So I'm thrilled to introduce our own Ashley Varner.
Thanks, Debbie. Thanks so much. And I'm not sure who you were just describing. So I appreciate you going through all of that. And thanks to all of you for being here today. It's a pleasure to get a chance to talk with you about domains of cognition and a little bit about staging toward the end. I hope that you're going to find the next hour to be well spent. We're going to spend some time first talking about domains of cognition and just the breadth of different ways that mild cognitive impairment and dementia can affect how people think. And then we're going to also be able to talk about how to work with these changes. That's really the crux of this, is how do we work with those changes rather than fighting against them? Because fighting against them usually just kind of results in frustration for everyone, for the person experiencing the changes, for care partners and loved ones, just frustration all the way around. Since this is a webinar and everyone is muted, I want to try to use the chat if we can. for some participation when I ask various questions today. So to get that started, if you would, in the chat, if you would take a moment to just tell me when you hear the words mild cognitive impairment or dementia, what's the first part of thinking that comes to mind as being impaired by these conditions? Okay, so I think that the chat must be disabled. So if you would type that into the Q&A box. I see memory. What else? Memory's the only thing. Loss. Okay. Yep, Peggy, I can see that. I'm glad you're here today. I see loss. Okay. That's a word that comes to mind. So loss of function. Isolation. Okay. I'm going for y'all areas of thinking that are affected. So areas like memory for sure that Kelly put in, but also some things that I don't know if you've ever thought about language or executive function. Are there other types of areas of thinking that you've experienced? Feelings. Yep, the ability to manage reason. I see that, LaPortia. Reality or perception. Good, good. Short-term memory, executive function. Thank you, Ed. Oh, I'm so glad you're on today, Ed. All right. So I'm going to go ahead and pull up my slides now, and we'll talk a little bit about these different domains. Because you got the point of that, which is just that this is about so much more than memory, even though we often think of it as being strictly memory. All right. And here we go. So there are many different ways that people can divide up different areas of cognition, but we're going to use these 8 today. Okay, so they include memory, which is, as somebody already pointed out, short-term and long-term, or can be divided into short-term and long-term. Language, which also has a couple of different divisions, both expressive language and receptive language. Abstract thought, organization, reason and judgment, which tend to go together a bit, perception, and attention or focus. So to get us started with that, if you would pop into the chat, what did you have to do to get here today? Let's just think for a minute about how you got here today. What did you have to do? Right? The first thing you had to do was hear about the webinar. So somehow, some way, you were paying attention to something that came across your desk that said, so attention, right? You were paying attention to something that came across your desk that told you about this. And then you were able to reason about whether or not it would be useful. You may have been curious about what it would include. So that's abstract thought right there, if I'm curious. And then you thought about taking part, maybe you sought advice that includes judgment and reasoning. You decided to take part. You blocked out the time on your calendar. Of course, that requires organization, and time requires abstract thought, although calendars do make it a bit more concrete. And then you arranged your schedule to be able to attend, which requires a great deal of organization. Maybe you had to plan for it to be for your lunch hour to be here at noontime. Or if you're in another time zone, you had to make the adjustments. You remembered to come, which is often I get emails that folks have forgotten to come and they want to know if it's online, and it will be online afterwards. And then you followed the directions to log on, which requires a pretty good bit of executive function, although we don't think about that anymore. And here you are, and you're behaving according to our guidelines. We help out some with that by having it be a webinar, but behaving according to the guidelines does require judgment, language, and attention. So you see that we're utilizing all of these domains of cognition on a daily basis and every moment. Very briefly, I think it can be helpful to get a sense of the brain functions by region of the brain. And it is important that both to note that dementia is a global neurodegenerative process. So eventually it affects all of the brain. However, different etiologies or different causes for dementia tend to affect some areas of the brain before others. So, for instance, Alzheimer's disease tends to show up in a degenerative process that happens in the hippocampi first, which are in the temporal lobes here. And that's where memory is, where our memory consolidation happens. And so that's why Alzheimer's so often starts with memory issues. On the other hand, our frontal lobe really is responsible for many, many things, but that include behavior. And so for somebody with frontotemporal dementia, especially where we can see that frontal lobe degeneration, their behavior may be very odd or unusual. Often folks with FTD find their way to a diagnosis either by involvement with law enforcement because of odd behaviors, or because things are changing in their relationships, especially in their partner relationship. And they go to therapy and it's realized that these changes are neurological. So this is just a sense of how things change. This is specific to AD, but we could change it, and it shows how the hippocampi is kind of the first area, and then it starts to spread throughout the brain. We could do the same type of diagram for any of our etiologies. And we're going to talk some about the different sources or etiologies of dementia. So we have our physicians and our advanced practice practitioners have some newer ways to diagnose some of the various etiologies or reasons, sources, diseases that cause dementia, mild cognitive impairment, and dementia. But this history component is always a component of the initial appointment and meeting and discussion and trying to figure out what's going on here. We're noticing these changes in thinking, but we're not sure. In here, in the center here, all of these symptoms, if you will, or changes in these different areas are common to all of the areas of dementia or mild cognitive impairment. However, there are some that are much more common and tend to appear first for various etiologies. For Alzheimer's disease, we often hear of a history of repetitive questioning or being repetitive in conversation. Folks are saying the same thing. Initially, it may be that they say the same thing within a 15 or a 30-minute period. And over time, they may say the same thing within a 5-minute period. For dementia with Lewy bodies, we see some differences with sleep, especially REM sleep disorder or acting out dreams. As I mentioned before, with frontotemporal dementia or degeneration, also known as FTD, we might see some changes in behavior, especially with behavior variant FTD. And then with progressive supranuclear palsy or PSP, we see falls most often as part of that history. That's what makes us begin to think, hey, is that what's going on here? I think more importantly here, if we think about cognitive and psychiatric features, with Alzheimer's, the change that we see most often is with memory, and especially, as Kelly mentioned earlier, short-term memory. With LBD or dementia with Lewy bodies, we often see hallucinations. And that can be one of the very earliest. And they tend to be hallucinations that folks see out of the side of their eye. But when they turn to look at it, it sometimes disappears. Often we also hear that folks see them and really do see them. And this is the perception area domain of cognition. And yet they know that nobody else is seeing it. Again, with frontotemporal dementia, we may see changes in behavior. And then with PSP, folks really notice a change in their executive function as one of the very first. But language and visuospatial changes tend to be pretty universal amongst all of the types of dementia. Okay, so what about these different domains? So with memory, what we notice is a loss of recent memories, things like, what did I have for breakfast this morning? And long-term memories and overlearned behaviors remain longer. So for instance, when I say an overlearned behavior, that may be something that somebody has done as part of their profession. So they've done a whole lot of it. I had the privilege of working with somebody who had driven cars from dealership to dealership, from car dealership to car dealership for his entire career. So he had been behind the wheel for years, and he drove safely and passed occupational therapy driving evaluations well into moderate stage dementia. Another example is many attorneys, especially trial attorneys, keep those verbal skills. But there is a gradual loss of detail in long-term memories, and eventually most memory does fade. That happens later in the process. So how can we work around these changes in memory? One is to keep in mind that learning depends on short-term memory. And why that's important is that new things, new skills that perhaps we routinely learn, things like when your smartphone is plugged in at night and it automatically updates itself. And there are some of the updates are rather large, right, y'all? And there are a good many changes the next morning. For those of us who don't have mild cognitive impairment or dementia, we may have to play with it a little bit, but we're able to adjust. However, this can be a major issue for somebody who is experiencing some challenges with short-term memory, because learning requires that short-term memory. So you may teach them and it doesn't stick. Similarly, getting a brand new smartphone can be, or even new appliances, right? I work with somebody who is their washing machine. She was sharing with me that her washing machine is on its last legs, and but she's determined to continue to use this washing machine because she's had it for 20 years and she knows that she won't be able to use a newfangled one. Newfangled was her word. Another really important consideration here is that we can't rely on our short-term memory anymore. So memory aids are like calendaring, like lists, like Post-its. like whiteboards, are really important and very useful. And the trick is that we're so used to relying on our memory that we sometimes think, especially early on, oh, I'll remember that. I can remember that. And kind of retraining ourselves, if you will, that we need to use whiteboards and encouraging our loved ones to use these memory aids. Enjoy the memory wins, but and the parentheses there is, but don't expect them. And avoid, as care partners and caregivers, we need to really work hard to avoid, don't you remember, or I just told you that. There's really no place for that. These are neurologic changes, and it's hard to remember, and I lose my patience on a routine basis with folks in my life. And they wouldn't be asking again if they remembered. So it doesn't really help. Similarly, memory tests or quizzes, things like what's my name, or name your grandchildren, or when did we get married? While it's tempting sometimes to do that because we think it's going to help, it's done with all good reason, with all good intention rather. It doesn't help, and it's usually just frustrating for everyone involved. Another domain is language and word finding. Difficulties can happen early, especially in Alzheimer's disease. Somebody just recently described to me that that for word finding, because I often hear that we all have trouble finding words, and that is absolutely the truth. Sometimes it's really hard for us to get out of our mouth what is in our head. We can't quite find the right word. And she said to me that word finding before was that if she would just kind of be quiet for a second, it would come to her. She could allow it to come, and it would kind of appear, if you will, if she was just still. And she said that now, and at least in her experience, that when she wants to find a word and she can't quite find it, it seems to sprout legs and run in the other direction. And I thought that was a great description. With language, there are two different issues that come up with the domain of language. One is expressive language, and that's the word finding. The other is receptive language, and that is hearing and processing and understanding what's being said. So some workarounds. With regard to word finding, as somebody with mild cognitive impairment or dementia, sometimes adapting to the fact that words are just going to be more difficult sometimes can be the goal. So otherwise, what happens if we're not able to adapt or accept that that's going to be more of a challenge, we get frustrated, and frustration makes everything worse. As a care partner, it's important to clarify whether somebody wants us to guess at the word or guess what they're trying to say, or whether they prefer to give them time, that we give them time to come up with the word themselves. And folks fall on both ends of that spectrum in my experience, but what tends to be more common is that they feel strongly about whichever end of the spectrum that they're on. We can use shorter and simpler sentences, and that's true for both folks experiencing language issues as well as care partners and caregivers. And then allowing 3 times as long for responses as we used to, and then multiplying that by 10 is a really good tip. Lots of patience, and we're not going to any fires, just kind of hanging out. Also, if we need to repeat for somebody what we said, repeating it the same way the second time. using the same words rather than changing how we say something. And then also with language, it's important to kind of keep in mind that verbal skills may actually mask a decline in other domains of cognition. Reason changes in the ability to reason may not be as prevalent early in Alzheimer's disease, but they are often very prevalent early in frontotemporal dementia, and they can be present with any etiology of mild cognitive impairment or dementia. And I think of reason as anything that comes after the word because. So reason is really a change, an impairment. Impaired reasoning is really an impaired ability to take a set of thoughts and information and relate that to what we consider to be an appropriate response or action. When reason begins to flag, this can cause the behavior of a person living with dementia or MCI to become a bit more random and self-centered, and that's a neurologic change. It's not a choice, it's a neurologic change. So what I mean by that is, for instance, somebody may want, when they have a question that pops into their head, they may want to get the answer to that question right away. And they're perhaps not able to reason that their loved one that they're asking is in the middle of something and can't be interrupted or shouldn't be interrupted because it's gonna delay things. They just want the answer. Another change in reason can be a change with kind of, and this is a little bit with includes many different domains, but a loss of social mores. So sometimes there is more difficulty with knowing where the boundaries are. Yesterday, somebody was saying to me that their loved one followed them right into the bathroom. They had, because the loved one had a question and she wanted to know right then. She wasn't able to reason or understand that there was a boundary there. So how do we work around this? Well, part of it is really understanding that insight requires reason. So expecting somebody with dementia to have insight, it's a gift when it happens, but it's not something that we can expect. And as care partners, we can stop when we hear ourselves say the word because. It's also helpful for us to just assess for the capacity for reason. And if we marry who we marry because we enjoy talking with them, we enjoy reasoning with them, we enjoy negotiating with them. And so if you're finding that negotiation is no longer productive, that's a pretty good clue that reason may be flagging. Related to reason is judgment. And with impairment in judgment, we worry about safety first and foremost. And y'all, that is physical safety, but it's also financial safety and emotional safety. Those with that, and the challenge is here that often with impaired judgment, people are not able to, the neurologic change also blocks the ability to recognize that judgment is impaired, right? If we knew it was impaired, we would fix that. So this is where it becomes much more incumbent upon care partners and caregivers to put things in place to protect our loved ones. We see changes in judgment when there's impulsivity or disinhibition, or conversely hesitancy. And often if folks are still driving, that's a place where we can see some changes in judgment, right? There may be, and that is perception as well, but it is judgment. People may pull out. They may not be able to judge distance, which is perception, but they may judge the distance, see the distance, but think, oh, I can do this. Or I'm going to, there may be more aggressive driving. There may also be more hesitance. Judgment can also make folks more insensitive, and or the lack of the impaired judgment may make folks that are experiencing this more insensitive. So how do we work with this? Well, one of the key ways is to remove opportunities for poor judgment. So we don't want folks to climb ladders, but if judgment is impaired, they may feel like, I've always gone up and cleaned the gutters myself. Why would I not do that? And so removing the ladder can be very important. Keeping in mind, another example of that is when folks start having issues with judgment, that's a really good time to have a driving evaluation or to discontinue driving. And if folks aren't excited about discontinuing driving, a lot of times it's a good time to get to remove the car or put it somewhere out of sight. Challenges with judgment are neurologic. So reasoning or negotiating becomes less and less productive. So I hear all the time with regard to, particularly driving falls into this category. But if you keep driving, you're putting us at financial risk. You might kill yourself. You might kill somebody else. Please don't drive anymore. Please don't, and that desire to negotiate and to reason with somebody to help them have all the information so they can make a good judgment. And the challenge right there is that it is impaired. And again, the environmental changes, we remove opportunities for poor judgment. If we know that somebody does not have great judgment, we may not want to ask them what they would like to do in a particular situation. But we may encourage them. We may present it in a way that encourages them to do what is with positive judgment. So an example of that is a very simple example of that is if we have a loved one who we're encouraging them to gain weight for whatever reason, we may want to, rather than say, "Are you hungry?" And have that be their choice, we may want to assume that they're going to have lunch with us. We're having X for lunch. We're having lunch now. I've mentioned some about perception. So misperception is the difficulty that folks have with interpreting what they are seeing. And this diagram kind of gives you a bit of an example of that. Additional issues with perception are that there is a very real capacity for overload that comes with mild cognitive impairment and dementia. Folks can feel overwhelmed much more easily. Their brain can be much more susceptible to that. And then we sometimes see suspiciousness or paranoia. And this shows up in lots of different ways. It can show up in sort of obsessive behaviors, locking the doors, getting up and checking the doors at night, wondering what's going on outside, looking out the window. Sometimes it shows up in a fear that a loved one is having an affair. So those are some of the ways that perception and challenges show up. So what are the workarounds? Well, as somebody with mild cognitive impairment or dementia, making room for enough to be enough. So we may, when we are going somewhere for the holidays, it can be a really great plan to have a quiet bedroom where we can gather ourselves and to either schedule time apart from a big group of folks, or know that we have that room and count on our loved ones. Similarly, as a care partner, we can monitor for that and look for those feelings of overwhelm. Especially with Lewy body dementia, it can be helpful to allow your loved one to tell you about the hallucinations that they're having, and not to confront them. So it's very tempting sometimes to say, "Oh, that's not there. There's nobody there. There are no children here. Nobody else is in the house but you and me." And we do that to reassure. That's absolutely what we do to reassure. The thing with issues with perception is that we don't realize it, but when I say that, I have just invalidated their reality, because for them it's very real. So instead, I may want to go with the perception that they have. And for instance, if they're hearing a band play, you might ask what instruments. There are, we don't want to go into the hallucination necessarily, but we can go alongside it. The one exception to this, of course, is safety issues. We have 3 more, and we're doing okay on time. Abstract thought is the domain of thinking that is the opposite of concrete thought. So some of the abstract thought that we manage on a daily basis and don't think twice about are, some of those areas are time, right? We can't see time. Distance. Money has actually become very abstract. Many of us on this call, I'm betting, are old enough to remember the days when we paid for everything or just about everything with cash. But that's really not the case anymore. Money is mostly in the cloud, and you click a button on Amazon and you've just purchased something. And that makes it much more difficult to kind of keep track of. It's very abstract. And relationships are abstract. I can't see a relationship. So our folks with mild cognitive impairment and dementia become increasingly concrete in thought. There tends to be an inability to think in what if I do something. And this makes empathy very challenging, because I can't, it takes abstract thought to be able to put myself in somebody else's shoes. So some considerations and some workarounds. Metaphors are really challenging if we don't have a strong capacity for abstract thought. So somebody was telling me about sending an email to somebody who said, and saying, what's a good window for me to bring the Christmas tree over? And the person wrote back and said, are you bringing it through the window? I thought you were bringing it through the door. So that inability to kind of think of window as a window of time. The more directive and concrete statements can be, the easier they are to digest. The more that we can make things concrete. So we make time concrete with a calendar where we put things, and if the calendar has hourly slots on it, that makes it even more concrete. Another workaround is to wait, for care partners, is to wait to discuss planned appointments until closer to the time of the appointment. So we're just not burdening somebody who's struggling with abstract thought with trying to manage something that's really difficult to manage. And then absolutely remembering not to take it personally. When somebody does not have empathy, when they seem rather apathetic, it is the disease, not the person. With regard to focus or attention, it's much harder for folks to, over time, the brain makes it much harder to stay on task. And some things that that can really help us to work around this, refocusing can be helpful. So as you see somebody's train of thought, bringing them back to the last thing that you said, perhaps. Fitting any activities to a time span or attention span is very helpful. And then removing distractions really does help. So when I first heard that one of the ways to help somebody with late middle stage or later stage dementia was to sit them facing a wall, I intuitively, that didn't make sense to me. I thought, well, that really excludes them. What I learned is that if they're doing an activity, that takes away a lot of the distractions. And if they're facing out into the room, there's going to be a million different things that might not have distracted them previously, but will now. And finally, organization is the final domain we're going to talk about. And what we find is that organization is very closely linked to executive function. So the size and complexity of tasks becomes very important because folks struggle more with how to do a multi-step process with all of the steps in the right order. We can work with challenges in organization by taking one step at a time or giving one step at a time. Providing the Goldilocks amount of redirection and focusing, and meaning the just right amount. And that's often very challenging, right? Because we don't know, as a care partner, we often don't know the just right amount. And so we're liable to hear, and this is just part of the deal, we're liable to hear, I already know that, or don't treat me like an invalid. I can do this myself. Or to have somebody kind of wander away, their thoughts to wander away. But if we're there to support and provide prompting, that can be extremely helpful. So consider the following, and y'all, if you'll answer this in the Q&A, how would you readjust? We're having dinner with your brother on Friday. What would be something that you could do what's a workaround that you could use in that situation? One of my colleagues is going to have to read if anything comes into the. There we go.
Okay, it says, one says, wait until Friday. Someone said, let them know the day of. Uh-oh, I just lost the chat again. Another one said, wait until Friday. Don't tell them ahead of time. Tell them we're having dinner with your brother today on Friday.
Excellent. Excellent. All right, let's go to the next one, y'all. Reason, abstraction, language. So if we can have hamburger tonight, then I won't have to go to the grocery store. How would you adjust that?